Uh, all right, Praneeth. So I will give you a clinical case scenario, just like what we have been doing before. I will take your thoughts and then we'll open it to discussion to anybody else. So
Sure.
again, nothing quite dramatic. Let's say there is a 38-year-old guy who comes to you because he had been tracking his blood pressure at home. He just bought a machine because his father's doctor told him that you guys should be checking blood pressure at home. So he had been checking his blood
Yeah.
pressure at home, and it seems to be running a little bit higher. He brings you a log, and his blood pressures are mostly running around 160s to 170s, and diastolic around hundreds. So in the last a month or so, he has done everything that he could. He went online, he read about it. He has visited doctor with his father, who also happens to have hypertension. So he has been doing a lot of what his doctor has told to his father, like salt restriction, exercise, trying to walk a little bit, um, and do some yoga and all this. But his blood pressure has not budged a lot. The logs still are around 160s or so. So he comes to you, you check his blood pressure in the office, and the blood pressure that you get is 160 by 100. He has got his father and uncle both having hypertension. So you do some screening questionnaire, you make sure that he's following all the good stuff, and then you decide that he's probably a good candidate for drug therapy. Uh, so you decide to put him on a drug therapy. His blood pressure is in the range where the JNC guidelines would suggest that you would put him on uh, dual therapy. You'll put him on a double drug right from the get-go. So you decide to choose two drugs, and just for the sake of it, I'm giving you example. This could be anything, but let's say you choose to put him on telmisartan 40 milligrams and amlodipine 5 milligrams a day. You also did some screening investigations to make sure there is no other problem. His kidney functions are fine, potassium parameters are okay, his TSH is okay. All of those things are fine. You did screening to make sure he's not having too much of anxiety or stress, because then you'll have to deal with that as well. So you took care of those part. You both of you made a decision that you should be on medical therapy. So here is the drug therapy that you both mutually agree on, which you think is going to work for him. Then he asks you the question, doctor, when should I take this medicine? In the morning or in the evening? So this is the clinical scenario for you. If you want to ask any particular question about this patient, please ask me, because we want the discussion to be directed on one particular case scenario rather than an abstract. You can choose different drug therapy to answer your question, but we are going to revolve around this particular patient. So tell me, Praneeth, tell me, Sartan amlodipine patient is asking you, when should I take it? How will you approach this question?
Yeah. So essentially, stage 2 hypertension requiring antihypertensives. So yes, I agree with starting to antihypertensives. So before I start the treatment, and as rightly asking me the questions, I would like to know about his occupation or his lifestyle, so to speak, as what does he work, what are his timings, or what, how does his day go? Is he like a software employee with a odd timings, or someone who is like a businessman having odd food habits, etc. So that I can usually my funda is to time with a meal, so that it kind of you are associating an activity which you do regularly, so that compliance rates are ensured better. So trying to know his lifestyle so that I can tag to one of his meals, something like that. Where I would like to know what do you do, what are your, how does your day go like?
Okay, so for this particular thing, Praneeth, I'll tell you, I work, let's say, I'm assistant in a law firm, and my work typically starts somewhere around 9 to 10 o'clock. I wake up at 7. I finish my work at around 5 to 6. By the time I reach home, it's 6:37. I go to bed at around 11. That's my overall day-to-day schedule. I take about 30 minutes evening walk every day.
Cool. So more like a regular office work related thing. So I would give you a prescription of telmisartan and amlodipine separately before because we haven't figured out your how much amount of antihypertensives that you are requiring. So initially, I will refrain from giving a fixed dose combination in the tablet. I'll give you separate tablets, and my prescription to you is take amlodipine in the morning and telmisartan in the evening. Amlodipine after your breakfast before you go to your work, and telmisartan in the evening after your dinner. That would be my prescription.
So let's say, Praneeth, to make it clear, so let's say if I take a breakfast at around somewhere around 8:30, so you would expect me to take medicine somewhere around 8:39 or so. That's probably what
Yeah.
you would suggest me.
Yes.
Okay, all right.
Yes.
So let us see. I will ask Dr. Devashish. I'm sorry, I'm going to pick on you. This is very important, and I think we'll see your perspective. We have reached up to this stage where we have decided this patient should be on true drug therapy. We chose telmisartan and amlodipine, and Praneeth thinks we should give one drug in the morning after breakfast, one in the evening. What is your take on it?
Uh, yes, hi, Anoop. Happy to join the call and take the question. The topic was interesting that that caught my attention. That is it worth discussing over 1 hour whether we give medicine in the morning or evening? But yes, there are a lot of nuances, and it would be worth discussing. Um, so I would agree with the prescription of telmisartan and amlodipine, and telmisartan 40 and amlodipine 5. Um, at the same time, given that this is a new hypertensive, and generally, even at the back of the mind, there is uh, a reluctance to take medicines and to incorporate taking medicines as a additional step in your whole routine. I would rather give it as a maybe separate tablets, but at the same time after breakfast, just to increase the chances of compliance. Both of these medicines have long half-life, and within 1 week or so, they should have stable levels over 24 hours. So unless his regular BP check shows that at some time the BP is dipping or sometime it's high, I think with one single day dosing, the blood pressure should be stable enough. So that's my perspective. I would advise him to take telmisartan 40 and amlodipine 5 just after his breakfast.
Perfect. Thanks, Devashish. So somewhere I read back in the day that the medications work only if you take it. So I think it is very important to look at the compliance issue as well. And that is where the FDCs or fixed dose combinations are trying to at least make the therapy much more streamlined. In fact, there is good data. I don't know if it is hypertension or not, but there is good data that if you give drug once a day versus twice a day, the moment you give something twice a day, the compliance rate drops. And that doesn't have to be the same drug given twice a day, or that has to be different drug given twice a day. So Devashish, your point is absolutely well taken that compliance is equally important. So every time when you choose morning or evening, you may have to also ask yourself that giving it 2 times, will it interfere with my compliance? That is absolutely fair discussion. Dr. Shastri, do I have you here?
I just joined.
Yes. So Dr. Shastri, we are talking about a 38-year-old guy who came to our OPD with no previous history, hypertensive, who we decided to put him on 2 drugs, telmisartan and amlodipine, new onset. We have screened for everything else. So we have reached this point where we have decided he will be on these 2 drugs. The question is, when should he take these 2 drugs? Telmisartan 40 milligrams once a day and amlodipine 5 milligrams once a day. The patient asks you when I should take it. He's a usual work. He's usual a worker. His work involves 9 to 5 job. No major stress in life. 30 minutes walking. what would you advise him when to take the medication?
I would prefer in the night. There is evidence in the recent past. I think the recent evidence I saw it in the Munich European Society of Cardiology meeting a year or a couple of years back, where the data has been shown and subsequently it is published also that antihypertensive drugs taken in the night time, they are better off. That is one publication. I can't give further details, but it seems to be better. And second thing is most often we are worried about the nocturnal dippers. The absence of nocturnal dipping is associated with more event rates, vascular event rates in the early morning hours. The telmisartan, there is a data, earlier data, which says though it is supposed to be 24 hours well controlling the blood pressure 24 hours, typically it doesn't really do it in the last 4 or 5 hours. So if somebody takes in the morning, morning time, AM, it is possible that you may not be having a very good control in the early morning hours. There was some publication about the 24 hours ambulatory BP also contrary to the expectation that telmisartan is a 24 hours drug. So considering these two facts, of late I have been advising all my patients to preferably take them in the night.
Do you say both the drugs at night, or would you say one drug in the morning and one at night?
Always, if you are giving combination, or either of the drugs or a combination of the drugs. If it is one drug or a combination pill, nowadays I am advising them to take in the night. There is no particular
But
advantage of taking in the morning time. On the other hand, there is some data which say that it is better to take in the night. And whenever
but
I
you
give
haven't.
two drugs, I always try to give them a combination pill.
But in this case, you have an option of giving separate if you think that will add clinical value. Do you think it will add clinical value to break it in and give one drug in the morning and one in the evening?
No, I don't see any particular reason. The most important thing is compliance. Just as I joined, somebody was mentioning about the compliance issues. The more number of pills somebody has to take, more times they has to take, definitely the compliance will come down. There is so much, it's a common sense and so much data. There is no disadvantage of combining them and giving them at one go.
Sir, I have a follow-up question. So when you give both the drugs at night, are you worried that at night his blood pressure may drop too much when he's sleeping?
I don't know. I don't think there is any evidence to say that. The very fact that the nocturnal administration of the antihypertensive drugs is beneficial, that must be occurring less often, and that generally should be a problem in very elderly patients where the cerebral circulation is impaired, and that is probably when you may be worried. Or otherwise, there is a severe significant vascular ischemia in multiple territories where you are worried about the drop in blood pressure, decreasing the perfusion pressure in ischemic events. In a 38-year-old male, unless he is symptomatic of nocturnal sweats or severe weakness or nightmares or whatever early morning weakness, unless some complaints like that, I would prefer to give in the night. I don't think it will be a worry in a 38-year-old person.
Sir, thank you so much for your thoughts. Anand, I will get back to you. Somebody's hand is up. Again, I cannot say your name. Your ID comes as 166. Please go ahead, whatever you have thought. Please go ahead. You are
Hello,
unmuted. Sorry, I don't have your name on my screen. Please go ahead.
I am Dr. Krishnam Raju.
Sir, oh my God. Okay. Thank you so much, sir. For some reason, your name was not coming up. Dr. Krishnan Raju is a very, very senior cardiology consultant at CARE. And sir, it is pleasure to have you. Please share your thoughts, sir.
Okay, senior but not geriatric.
You are not geriatric, yeah. Please go ahead, sir.
Yeah, just to follow on what Dr. Shastri has said, one way of knowing how a particular individual will require a nocturnal dosing of the antihypertensive drug will be by doing a 24 hours ambulatory blood pressure recording, which I have been doing on some select patients. Then you know whether a particular patient has a hypertensive surge in the night or he has a nocturnal dip. So majority of the normal people have something like a 20 to 30 millimeter dip in the night. They are called normal dippers. Some people don't dip at all, that is abnormal. Some people actually have a higher pressure during sleep. That is even more abnormal. This is the group of people who have a higher cardiovascular, events, morbidity, etc., etc. And they are also the specific group of people who will be benefited by a nocturnal dosing of at least one antihypertensive drug, which does not produce postural hypotension. Like for example, if you give a progestin or alpha blocker in the night, it is possible that they may, once they get up to go to washroom, many of them do develop a kind of syncope, or they have falls, they break their bones, hip fractures, etc., etc. So one way of deciding is, one, if somebody is requiring only one drug, monotherapy, it is okay to give it in the morning, not necessarily after breakfast, because the epidemiology of the blood pressure and cardiovascular disease has repeatedly suggested that all the cardiovascular events like stroke, MI, and acute coronary syndrome, etc., peak around 10 to 11 a.m. So that is the reason why you need to have the best blood pressure in the morning hours. So one dosing, normally my practice is to give around 7 to 8 in the morning. Breakfast or no breakfast doesn't matter. And if they are requiring two or more antihypertensives, it is okay to give the second drug in the night, but not a postural hypotensive drug. Third, if they particularly have a nocturnal is a non-dipper or has a hypertensive surge in the nights, that is the definitive indication to give the second or third drug in the night. And telmisartan, my own experience, alone as a lone drug, is not a great antihypertensive unless you club it with a thiazide. With thiazide, it is okay, but without thiazide, it is not a great antihypertensive drug in my own practice for the last so many years. So that's what I would do personally.
Thank you so much, sir. Please be with us because I'm sure that a lot of what we are going to say will not sound correct, and then you can correct us in between. Anand, you had something to say. Anand, please unmute yourself.
Hello.
Yes.
Yeah. Once you have thought that you have to keep two drugs, first preference for me will be the calcium channel blockers, amlodipine, which preferably I will give in the morning along with telmisartan, because unless I follow up the patient for 1 week, I don't give in the evening actually, because compliance is mainly affected. If you give a two drugs morning and evening for the initial start, patient will not have a monitoring for that. Next, how the blood pressure is responding after 1 week. What is the blood pressure in the morning, afternoon, and the night? Based on that, I will change the drug whether to give in the morning or night. So both drugs I will be giving in the morning, preferably around 8 o'clock, and you may split the second dose by 1 hour like that. So 8 to 9 o'clock you will give a second dose, and I will monitor for 1 week. Yeah.
Perfect. Thank you, Dr. Anand. Thank you so much. Praneet, you had a follow-up comment?
Yeah, so my selection of giving the ST inhibitor or the ARB in the evening and the calcium channel blocker in the morning, based on my reading somewhere, somewhere I read that the ACE inhibitors or ARBs to be given in the evening time better. Probably one of the statement to justify the decision would be that the renin-angiotensin aldosterone system activation is high during evening time compared to morning time, which is where it is being suggested to give ACE inhibitors and ARBs in the evening time than the morning time. That is where I chose to give ARB in the evening and calcium channel blocker in the morning.
Praneet, that point is well taken. I certainly recollect lot of such I wouldn't say data because it's really not a data. It's more like a observation based upon whatever biology we know, that the body's circadian rhythm certainly promotes or certainly suggests that the renin-angiotensin system is far more active during nighttime, evening and nighttime, and that is where giving ACE inhibitors in the evening, and by that extension giving ARB in the evening, there is no thought on ARB, it's on ACE inhibitor. We are using ARB only as an extension. It certainly seems to add some value to give that in the evening as compared to in the morning. And I have seen a lot of practices where people do give, I myself give ARB in the evening, partly also because I don't want them to get first dose effect in the morning, but primarily because of this renin-angiotensin. Dr. Chandramukhi, can I have your thought on this? Were you with us during the case discussion? Can I have your thought on this particular situation?
Yeah, I joined a little late, but
Okay.
the discussion point is like the patient is on 2-drug regime, and what is the ideal time to give the drugs?
Yes, 38-year-old guy, no other risk factors, otherwise things are all right.
Yeah, so like initially I will be putting the patient on one drug. It may be like calcium channel blocker or ACE inhibitor, and I will follow him up for a period of about 1 week or 2 weeks. And still, if his blood pressure is not controlled, then I will go for a second drug. So the first drug, I will usually in my practice, I give the first drug in the morning. I tell the patient to take it in the morning. It may be, it should not be related to the meals in the morning, but the time when he takes, it should be fixed time. Like whatever time he takes, either in the 8 o'clock in the morning or 10 o'clock in the morning, it should be fixed, and there should not be much variation of that time. The relation to food is not very strict. So the drug can be taken either before food or after food. It is not related. And if even with one drug it is not controlled, then I will add a second drug. And the second drug will be preferably given in the night time, as already it has been explained about the night dip and early morning surge and early morning rise in the BP. So the first drug in the morning and the second drug addition, it should be in the evening. And whenever I'm adding 2 drugs, I will clearly explain to the patients regarding the drug compliance and the complications of uncontrolled BP, so that he has to follow the drugs and take the drugs in time.
Perfect. Thank you so much, ma'am. Dr. Krishnam Raju, sir, you had a comment on this?
Most or almost all the antihypertensive drugs have nothing to do with food. I always find it useful to give a specific timing to the patient. Normally, I do so 8 a.m. plus minus half an hour, except in the case where I am using a spironolactone. Spironolactone has to be necessarily be taken along with food. Spironolactone may be the drug of choice in certain hypertensives, like for example, oral contraceptive induced hypertension or adrenal cortex induced hypertension. The spironolactone is an essential drug to be used. If that is so, necessarily I would give it in the morning and always with food.
Sir, what is the theory behind? Yeah,
the
sorry.
theory behind the pharmacodynamics and kinetics show that its absorption apparently is very good along with the food, and on an empty stomach, it seems to be probably interacting with the gastric acid and deactivated.
All right. I will bring Praveen here. Praveen Nagula, he is assistant professor at Osmania. It was his suggested topic. So Praveen, he joined a little bit late. We are talking about a 38-year-old guy who comes to your OPD. You decide to put him on 2 drugs. So up till this point, we have made the decision. Amlodipine 40 and amlodipine 5 and telmisartan 40. What time? What would you suggest?
Sir, I would be suggesting calcium channel blocker in the morning and ACE inhibitors in the night. Why? Because of the activation of renin-angiotensin system in the night. And if particularly if the patient after 24 hours ambulatory blood pressure monitoring, if it has been analyzed and he is not showing adequate dip, I would suggest a combination drug also in the night compared to that of in the morning. And for the if the patient is not having adequate dip or anything, is having a BP surge, I would recommend a newer calcium channel blocker in the morning rather than that of an amlodipine.
So I am amazed about how many times we brought up ambulatory blood pressure recording. I don't know I am that liberal in ordering, particularly when I'm managing run-of-the-mill hypertension. So if you guys are tailoring your therapy based upon your ambulatory blood pressure recording, that is very innovative. It is how it should be done. It is just that I don't see a lot of people in front of my eyes doing it. I myself don't do it that frequently. I believe in the last 1 month, I may have ordered one ambulatory blood pressure recording. So if we are doing that, that's very good. If we are not doing that, but if that is the answer, then it's kind of a bit, then it's more of a theory than anything else. We have Dr. Johan here. Dr. Johan is one of our senior consultant cardiologists at CARE. Sir, we are talking about a 38-year-old guy whom we decided to put on two antihypertensive because the guy's blood pressure is high. We decided to put him on telmisartan 40 and amlodipine 5. He's otherwise okay, no medical problems, no risk factors, labs are all right. And he's asking us when should be the best time to take these two medications. What is your thought on it?
Yeah, Anoop, sorry, I'm late. But actually, if you look at the choices, and Anoop by themselves have possibly the two longest half-lives in the business. Look at the standard kind of anti-hypertensive.
Voice is breaking a lot. We can only hear few words in between.
Yeah, can you hear now? I'll just put on.
No, still very bad. Still very bad. Can't hear you.
I'll just put on the speaker. Just give me a
Yeah. Sir, we'll get back to you. We'll get back to you in 2 minutes. Hopefully your audio will get a little bit better. Dr. Krishnan Raju, you have any more comments? I see your hand is raised up.
That will illustrate the usage of the drugs. This is a retired High Court justice. He would have drugs taking one in the morning, calcium blocker, clinidipine, 8 a.m. and 8 p.m. The next dose, around 10 milligrams, about 8 p.m., which means twice a day. And throughout the day, his blood pressure is normal. He's happy. He has a system at home, so he records it whenever he wants to. And consistently, his blood pressure around 8, 9 in the night is 200 by 110. But during all the daytime, it is well under control. So I got an ambulatory blood pressure recording done and shifted the 8 p.m. dose to 6 p.m. Okay, after shifting that to the 6 p.m., now all 24-hour blood pressure is around 130 to 140 by 70 to 80. So which illustrates that in a given patient, it might be useful to do an ambulatory blood pressure recording so that you can distribute the drug, dispense the drug in such a way that its peak action is during the highest blood pressure period. So you have to keep in mind the pharmacodynamics and kinetics so as to time the drug. It need not necessarily be twice a day, need not necessarily be 8 a.m. 8 p.m. It could be 8 a.m. and sometime in the evening, depending on how the blood pressure is behaving throughout the 24 hours time. So that is one benefit of an ambulatory blood pressure recording. This is something that has happened last month. So I thought I will illustrate that.
Perfect. Thank you so much, sir. I will open the forum. Anybody who has any thoughts on this or even the choice of drug, if anybody wanted to put some other drug as one of the starting therapy or add-on therapy, and when would you time that drug? You can please unmute yourself and share your thoughts.
Anoop, if I can just
Johan,
make a
sir.
mention.
Yes,
Yeah.
yes, you are very clear now. Please go.
Yeah, so Anoop, just following up with what Dr. Krishnaraju sir told us, especially in a patient where you're suspecting or have a suspicion of a masked hypertension,
that is a high blood pressure at home and a normal pressure at the clinic, or a white coat hypertension wherein his pressures are good in his home and his peaking pressures at your clinic, or you have a patient who has fairly normal or mildly raised blood pressures, 140s, 138s, but has significant TOD, target organ damage. These are very good cases to have an ambulatory blood pressure because two or three things we get to know. One is, as Sir said rightly, we get to know what is his peaks and troughs, which may not be the peaks and troughs what you are trying to give in terms of blood pressure medication. Second thing is he a dipper or not? Is he a night dipper or not? Which has a lot of bearing on target organ damage. And also, what is his surge like in the early morning? And based on these two things, we can actually titrate both the which kind of drug, and also you get heart rate as well. You get a pulse rate or a heart rate. So the addition or non-addition of beta blocker again becomes crucial. So if he's peaking his blood pressure along with a symptomatic rise in the pulse rate, that is the heart rate goes up and the pressure goes up, adding a beta blocker at that stage would be a good choice. Although notwithstanding the guidelines saying that beta blocker is the last choice. And again, timing the drug just before that peak again makes a big difference. And Sir has very beautifully illustrated that point, wherein your 8 a.m. and 8 p.m. may not be the time when his blood pressure. So it gives a little bit of an individualization of pressures, especially in this situation, and does not need to be done on every patient. It's really not required. So I think this is what it does. As far as the choice goes, both the choices I believe are good because both are long acting, almost nearing 24-hour action, and both are complementary to each other. Both the calcium channel and the ARB which you've chosen are fairly complementary. So I think they're fairly good choices. That's all from my side.
Thank you so much. The forum is open. Anybody who has got any thoughts, or you can choose a different drug and tell us how would you time that in the next 5-10 minutes. Then I'll go to scenario number 2. Yes,
Look,
Dr.
just I would like to make a couple of comments,
Sir.
not directly related to this. See, there are different ways of measuring the blood pressure at home. The probably appropriate scientific method is 24 hours ambulatory BP, but it is cumbersome nuisance if we only have to have it all the time, every 15 minutes, the arm being compressed and the blood pressure being mentioned. So, and also it has to be done, attached to the hospital, it has to come, remove it and go and all that. Though I do it not very frequently, on the other hand, especially if somebody is diagnosed with hypertension and requires treatment, it is going to be your lifelong friend. I encourage them to buy a BP instrument. Most of the time, there are problems with the Android or electronic BP measurements, but that is a practical step. Not only I encourage them to buy the instrument and check it, measure blood pressure at home in different times and make a record. I also encourage them at least to bring it periodically to the hospital and compare with the regular mercury manometer that is checked. With you cross check whether how the instrument is working. This is a practical way. I don't say this is very scientific, but this will take care of this masked hypertension and white coat hypertension. This just point, and also since we are here, there are distinctly some patients who respond very well differently to ARBs, and some respond very well to calcium channel blockers. I'm little hesitant to, in spite of the guidelines, I'm personally hesitant to start diuretics, especially hydrochlorothiazide and chlorthalidone. The reason being hyponatremia is very, very common in our population for some reason. Most of us, in spite of telling repeatedly, we miss the patients in the initial hyponatremia are supposed to check after a couple of weeks, especially if you give a combination of ARB and diuretic, hyponatremia occurs very often. So if I choose to give a combination, then I insist the patient come back and monitor the serum electrolytes at least once after 2 weeks or 4 weeks. And finally, whenever you choose calcium channel blockers, you said amlodipine. I'm perfectly fine with amlodipine, but one of the very common mistakes done in the practice is the nifedipine has to be given if it is non-sustained release preparation 3 or 4 times a day. Many times it is pathetic to see nifedipine non-sustained release as once a day. That will never control the blood pressure. If it is only sustained release, you can give it twice a day. Same with cilindipine. Cilindipine action is about 12 hours, and you cannot just give once a day and get away with the 24 hours control. Similarly, losartan. Losartan has to be given twice a day, not once a day. Whereas telmisartan and olmesartan you can give once a day. So these pharmacokinetic aspects have to be very clearly understood when we are prescribing any of these antihypertensive agents, whether it has to be given once a day or twice a day. Thank you.
Thank you so much, sir. Dr. Krishnamraju, I'm going to get back to you. In fact, I want to get back to you for a different case scenario. Anybody else has any other thoughts on this? Whatever we have discussed so far, anybody who has not shared his thought yet or her thought yet? Okay, so I will just highlight 2 or 3 points which were discussed here. So the study that Dr. Shastri was mentioning, which he heard in Munich last year, the study was published, I believe, from Spain, and that so-called dipper versus non-dipper thing. And it's an all-comer, where you give a drug in the morning versus evening. And when we are looking at hypertension control, we are looking at 2 things. One, which ambulatory BP machine will tell you, and that is how the blood pressure is getting controlled. But the other thing that the ambulatory blood pressure monitoring will not tell you, which is what are the hard clinical endpoints. Because at the end of the day, we want MI to be less, we want stroke to be less, we want heart failure to be less. And more data we look at, more and more data suggests that taking medications at night time improves these clinical hard endpoints: stroke, heart failure, and MI. And we are talking about all comers. We are not talking about patients with established atherosclerotic coronary artery disease or vascular disease. We are talking about those patients on whom we are giving antihypertensive therapy with the aim to prevent those. And in those, good portion of studies, they point out that just giving it at night is associated with improved heart clinical endpoint. The second thing is about that ACE inhibitor, which was already brought in in the evening with regard to the circadian rhythm. The third thing is about the long-acting preparation. Most of the long-acting preparation, if you go back and look into how the drug was manufactured or created, most of these drugs, they are kind of, I hate to use this word, they were pushed to be called as a 24-hour drug. In fact, there is rarely a drug which is a 24-hour drug. Most of these drugs, they run short of 24 hours. They are promoted as 24 hours because of rule number 1, that blood pressure will get better only if you take it. So the idea here was that you give a long-acting drug at least so that people will start taking it. So at least you will get 18-hour, 20-hour benefit, if not 24-hour benefit. So all the so-called long-acting drugs that we are looking at, they are not necessarily a 24-hour drug. That is why many of the times you see twice a day drug being prescribed even for longer acting preparation, just because that extra gap, there is that mismatch which you see in most of the long acting drugs. Now, when we talk about timing of the drugs, I gave you a very simple clinical scenario. That is why I wanted to bring a second clinical scenario, which is equally more important. And this is where, Dr. Krishnamraju, I need your opinion, and then we will discuss further. So I'm just going to change this clinical scenario. Now, let's say this is a 58-year-old guy who had a previous stent, and he's otherwise fine. He just has some exertional stable angina, which you have decided to manage medically. He's on beta blockers, and he is on calcium channel blocker. And he takes both of them at night because his doctor told him that taking at night is better. He comes to you now, you are seeing him for the first time. We are not talking about coronary revascularization. We are talking about medical management of this patient. His blood pressure is 160 by 100. And he is having daytime stable exertional angina. So we have to manage his blood pressure and at the same time manage his angina. So now we are talking about how to change his medical therapy and how to time it. So I will ask for your opinion. This guy is on beta blocker and amlodipine at night. Echo is okay, otherwise fine, stable angina. Sir, the floor is yours.
Is that for me?
How would you change the medication and how would you change the timing of it?
So the lead symptom of the patient in question is exertional angina. So obviously the drug of choice is a beta blocker. If that is so, we have to move the beta blocker to the morning. and move it to the morning and give adequate dose. And if necessary, you could add a nitrate or nitrate-like drug like nicorandil and leave the other antihypertensive drug in the night. And of course, I understand that he should be on his antiplatelets and statin as usual. So that should be fine. The only thing we are doing is because of his exertional angina, the choice drug will be a beta blocker and the exertion will be during the daytime. So move it to the morning.
Calcium channel blocker, sir. Dihydropyridine calcium channel blocker, giving it in the morning or evening in a patient who's having stable angina. What is your thought?
If it is a long-acting calcium channel blocker, like something like amlodipine, right? S-amlodipine, then it's okay to give it either in the morning or in the night. Or because the lead symptom is angina, it is also okay to move it to the morning. But probably what I would do is move the beta blocker morning and continue the calcium channel blocker in the night and follow up with the anginal diary. I don't know whether you are, familiar with that word angina diary. So 25 years back, we used to ask all our angina patients to keep a diary of their anginal events. So at the end of 1 month, when they come back for the checkup, we not only check them physically and symptoms, but also check the angina diary and note what is the frequency of the angina, duration of the angina, timing of the angina, and timing of the angina related to the activity. Depending on that, we would juggle the drugs.
Thank you so much, sir. Now, if you do say about maintaining angina diary and everything, then I think people will start referring you as a geriatric doctor. So that will just tell you that for how many years you have been practicing. Praneeth just messaged me saying the trial that we have been talking about, that trial's name is Hygia chromotherapy trial. Hygia chromotherapy trial. So in case if somebody is
Chronotherapy.
chronotherapy. So in case if somebody is interested, they can look at it. It's a good trial. It's a good thing to learn. Dr. Shastri, how would you manage this patient? 58-year-old guy, stable angina, but it is disturbing him. And we want to manage his medical therapy. His blood pressure is high. So we are talking about changing the therapy, but also timing. How are you going to time his therapy?
See, whenever you have got stable angina, it has to be very clearly understood. It is a ischemia. Ischemia is a demand-supply mismatch, and ischemia demand is double product. Double product is systolic blood pressure into heart rate. If you decide to manage medically on medical stable angina on medical management, and his angina is still not controlled, you have to bring down the heart rate to 60 beats per minute, minimum at rest, and not more than 10% or 70 to 80 with exertion. I forgot the exact number, somebody may correct it. But baseline heart rate, you want to bring it to 60 beats per minute. So when you're talking about beta blockers, you didn't tell me which beta blocker you are using. And also the beta blocker response depends on the molecule. The heart rate reduction depends on the molecule, as well as the individual variation will be there. Some people may require 25 milligrams of metoprolol succinate, whereas somebody may require 10 milligrams of bisoprolol. So people, whenever you are talking about beta blockers, their efficacy, you have to correlate them with the maximum dose. Roughly, for in the modern practice, there is hardly any role for metoprolol tartrate. When we are talking metoprolol, we generally mean metoprolol succinate. A metoprolol succinate of 200 milligrams is roughly equal to bisoprolol of 10 milligrams is equal to atenolol of 100 milligrams or nebivolol of 20 milligrams and carvedilol of 50 milligram BD. So we have to know what dose he is on, and some beta blockers have to be given twice a day, like carvedilol and metoprolol tartrate, whereas bisoprolol and atenolol you can give once a day. So depending on that, what kind of molecule you are to give and whether the patient has intrinsic symptom, bronchial activity, allergic tendency is there, hyperactivity is there or not, you can choose the beta blocker. And accordingly, you uptitrate the beta blocker, either you increase the dose fully or preferably give it in the morning so that you have 24 hours, as you mentioned, 24 hours control will be there. There are some patients who respond very well to beta blockers. But my personal opinion, I'm totally biased in favor of calcium channel blockers. I find them to be one of the wonderful drugs, especially if you've got a difficult to maintain, bring down the hypertension. So my choice will be you give a combination of amlodipine, which I have biased for in favor, and additional beta blocker as much as you can increase to bring down the heart rate to 60 per minute. Sometimes I'm not sure. Suppose the metoprolol is not able to bring down the beta heart rate, I would prefer to change over to either generally so I give a higher dose of beta blocker and amlodipine in the morning time.
So that was my question to you, sir. Amlodipine, you would choose morning time in this case?
Yeah, morning time I'll choose. So already you are giving in the night, so I would rather bring in another drug in the morning time.
Okay. All right. Anybody has any other thoughts on the two cases that we discussed about the timing? Because in the first one, we are simply talking about antihypertensive response and preventing clinical hard endpoints. In the second case, we have one more target to fix, which is exertional angina, which mostly happens during the daytime. So now you have to take that into account as well. So Praneeth, I see your hand is up. Your thoughts, please.
Yeah, so as I was kind of browsing through, as I mentioned or went through the IGIA project, which they are doing a study with ambulatory blood pressure in more than 20,000 patients, 30,000 patients, doing or requiring all ambulatory blood pressure measurements. So this was predominantly done in Spain. Probably ethnicity also varies.
Voice is not clear, Praneeth, please loud. Please speak loudly.
Well, now?
You're good now. Yes, Praneeth, you're good.
Yeah, so probably ethnicity is what it varies. On a similar note, which when I was browsing, what I came across was another article which was about the Hope Asia study. The Hope Asia study was specifically looking at the outcomes of hypertension or the circadian rhythm variability in Asian subsets, particularly all the South Asian countries, where they found out that the sympathetic activity was higher in the Asian population. The salt sensitivity was also on higher in the Asian population. So the Hygia chronotherapy study, the sleep ambulatory sleep blood pressure, sleep mean blood pressure, so to speak, which was most important predictor in those subset of people. The Hope Asia study says that the Asian population had predominantly three phases where the blood pressure was high. The one which was the early morning awake pressure. The third was the regular daytime blood pressure. The third one was the nighttime blood pressure. And among the various time frames where the blood pressure timing of when the blood pressure was high and which was leading to cardiovascular events, in the Asian subset of people, what they found out was the early morning blood pressure to be most important predictor of cardiovascular events. So more so, it probably makes sense to give the antihypertensive therapy also for the Asian subset. India is also one of the countries which was studied, Chennai being one of the centers. So giving antihypertensive in the evening, and if we are looking at ambulatory blood pressure measurements, the awake blood pressure has been said to be one of the important predictors of cardiovascular events in the Hope Asia study.
Okay, thank you. We talked about some science. Anybody else has any other thoughts on this? There was one question which was asked by an audience. I'm going to just put it up. I don't know the answer. Anybody who knows the answer, please unmute yourself and answer it. The question is, when we do ambulatory blood pressure monitoring, it is uncomfortable to the person, which is of course because it's unnatural. Does it give you a falsely elevated blood pressure, particularly at night? Anybody who has used ambulatory BP monitoring more frequently can unmute themselves. Yes, sir, Dr. Krishnam Raju.
It is true, you are not going to do it every day. So it is only a diagnostic test into the rhythm of the blood pressure values during the 24 hours, particularly during the night. So when you are not every day is not a significant problem as such. But I haven't found any patient complaining because I do it. I wouldn't say I don't ask for it every day, but frequently. But none of my patients had ever complained about any discomfort at all. Neither their sleep was disturbed, nor did they complain of any discomfort. To add on to that, one point which was talked about earlier of the digital BP apparatus at home, I think which Dr. Shastri was mentioning, the current advice on that is you need to take at least 10 readings each time and take the mean of that. You can't take one digital blood pressure reading and be stuck on to that. But each time you want to record, you have to take 10 of them and take the mean of that, which I don't think even a single cardiologist in the globe will do it. Nobody. So there's a new equipment which has come into the market. It by itself takes 10 readings and displays the mean.
Dr. Shastri, you're unmuted. Anything?
Yeah. Just I don't know. I mean, Dr. Samdra, Dr. Krishnaraj sir is so knowledgeable. I take it immediately on the face value. But I wanted to know what is the major trial which was the last trial done in the hypertension, very major trial, where the target blood pressure is 130/80. The blood pressure measurement in that what is that, Anoop? You remember? Very major trial, 4 years back it came. Where the target is fixed at 130/80, done in predominantly non-diabetic patients, elderly people. Now
Okay, sorry. Go ahead.
Yeah, I forgot the major trial name. In that particular trial, the blood pressure measurement was done by a electronic BP instrument, but funnily, they didn't take 10 measurements. They made the patient sit in a room for 5-10 minutes quietly and check the two blood pressure recordings measured 5 minutes apart. So that was the thing. This information that you have to do 10 times is, I'm very surprised. I never read. But it's really, if that is a recommendation, that is going to be very cumbersome. What generally I advise the patients, I don't know, subject to correction. So somebody like Krishan Raj or anybody can correct me. You tell the patient to sit in a chair quietly with both the feet touching the ground, sit quietly for 5-10 minutes, avoid all the situations will increase the blood pressure, and check the blood pressure 5 minutes apart and take the average of the two unless they are quite different. I don't know. I would like to be corrected on this recommendation, but 10 values is something which is very impractical.
Okay, Dr. Shastri sir. Okay, we'll discuss this offline because again, this is not the key discussion we are having. One question that came up was hydrochlorothiazide or thiazide drugs, morning or evening. I think that is quite clear. We typically give it in the morning because of, even if it has got a little bit of diuresis or natriuresis effect, we want to make sure it happens in the daytime as compared to at the nighttime. Anybody else has any other thoughts on this? You can unmute yourself. In the meantime, I'll just keep my rant. So few things I will tell you which have some data backing, just random thoughts about morning versus evening. So if you start beta blocker early on, particularly person whom you are starting for the first time, beta blocker is associated with fatigue. If you give it in the morning, typically the compliance rates or the quit rate is higher as compared to in the evening, because in the morning they feel very much lethargic, malaise during the daytime. That's actually true for most of the antihypertensive therapy, because see, hypertension most of the time is not an acute thing. This is building up over the period of time. So when you give a drug therapy, there is an acute drop in blood pressure, which body doesn't like. They respond typically as weakness, lethargy, unable to do things, and weakness and whatnot. So these patients giving medication early in the morning, they see a significant drop in their physical activity or stamina, what they call it. So many of the times you can improve the compliance by giving it in the evening. Also, the data suggests that evening is better. So more and more we learn about it, more and more we realize that drugs given in the evening have a better effect. Dihydropyridine calcium channel blockers, we struggle with leg edema. There is data to suggest that calcium channel blockers, if given in the evening, they typically have less edema as compared to people who take it in the morning. So calcium channel blockers, dihydropyridine, we typically give it in the morning if we are chasing angina, but otherwise there is good data to say in the evening. Hope trial, which literally was just a ramipril advertisement, but that did prove the point that that circadian rhythm does exist, and ramipril giving in the evening, it helps, and by that extension, every other ACE inhibitor or ARB for that matter. Beta blocker giving it in the evening, there is one problem associated, which is bradycardia if it happens in the night time. Again, patients most of the time they will sleep through. There are 2-3 subsets of patients where you are worried about. Dr. Shastri did mention one of them, and that is elderly patient who have got dementia or cerebral hypoperfusion. If you give all the drugs to them at night, during night time, they may have cerebral hypoperfusion, and that may manifest as early morning strokes or early morning those watershed areas. They may have progression of dementia. So it is recommended that patients who are at high risk for dementia, we try not to dip their blood pressure at night too much. There is some thought about vision as well. People who have vision disturbances, not optic neuritis, but you know that same cerebral perfusion thing. So people who have risk factors for that. There are case reports of people waking up in the morning with low vision or blind eye. And some of the thought process was that maybe because they had such a high degree of hypotension at night, which they slept through, that it caused cerebral cerebral hypoperfusion. So a lot of these things are there. I think the patient profile is important, particularly when you're dealing with a cardiac patient. But in a random run-of-the-mill hypertension, there is good evolving data that we should be targeting that early morning surge. And to target that, the evening dosing is probably going to be better. The choice of drug, that is totally on you, and that's altogether a different topic to talk about, like which drug should be better. That I think is altogether a different session. But regardless of what drug you choose, except few nuances, like postural hypotension, Dr. Krishnan Raju suggested that he gives it in the morning so that the patient should not fall at night when he wakes up for bathroom. In fact, I always used to think the other way around. I used to think that drugs which causes postural hypertension, you should give it in the evening so that they sleep the whole thing through so that they don't develop that postural hypertension thing during the daytime. So I time my alpha blockers at night. I time my ACE inhibitors, particularly first dose effect early on at night for that same reason, so that they don't develop, they don't have a fall. But again, the thought process of Dr. Krishnan Raju, as what Dr. Shastri said, you have to take it at the face value. But this is what I have been doing so far. So that was my rant on the timing of it. There is some science behind it. There is some data behind it. A lot of it is practice. And for individual patient, I think it is very important to individualize what they are doing. There is some data on kidney disease as well. That is all that I had. Dr. Krishnan Raju, I'll get your closing comments and then anybody else who has got any other thoughts. Dr. Krishnan Raju.
I think the ultimate goal is to get the blood pressure down to its normal levels, approved normal levels, which has been varying from study to study and SC to ESC to WHO. But let us assume 130 by 80 or 130 by 70 is the norm. So no matter what drug you use, as long as you can get the blood pressure down to that level all 24 hours, all days, that's good enough. So the choice of your drug may or may not depend on the other comorbidities, though preferably they would. The second I would say is shift work. There is a problem. The large number of now are working in shifts, particularly these technology workers. So they work in shifts. Now, I don't know personally of any particular study of these people, how the pressure behaves and how the antihypertensive drug behave and control them, and how to time these antihypertensive drugs in those patients. I don't think I have any information, but that is a significant number of population now in the country and everywhere. So the another thing which you mentioned about this alpha blockers you use in the night and I was suggesting in the morning. That again has to be individualized. If you have a patient who is frequently in the night to go to washroom for any other reason, they are prone to particularly postural hypotension and falls and injuries. Suppose they don't wake up at all in the night, there is no such issue. It doesn't matter whether you give in the night or in the morning. So these are the few things. I think ultimately it boils down to get your drugs to control the blood pressure to normal level all time of the day and night. That is fundamental. How you do it obviously will be prescription habits, and you could choose whatever each one of you have experience with, because the golden rule is always use the drugs you are familiar with, and you know their side effects, you know how to tweak the drug.
Perfect. Thank you so much, sir. Dr. Devashish, we did talk for 1 hour on antihypertensive, and probably we can, based on clinical scenarios, we can discuss some more. Your closing comments on this?
Thanks, Anoop. It was a wonderful session. And I love the format that you've chosen, which is a conversational format. People just talking about what we actually do in practice and our reasoning behind that. And a lot of that is based on science, some based on latest research, some based on basic science, and a lot based on common sense. And I love the last thoughts that we are leaving everyone with. Get the blood pressure down. And if you need to individualize therapy based on the patient's characteristics and their ambulatory blood pressure monitoring, that's the best thing.
Thank you. Praneeth, your closing comments. And remember, we are still waiting for thoughts from other attendees who have not spoken yet. So if you have anything, you please unmute yourself and you can speak. And while you think about that, while you get your thoughts gathered, Praneeth, your closing comment on this.
A lot of points clarified, a lot of points learned about how to change our things, and as clearly being concluded by Dr. Krishnamurthy sir about individualizing and be comfortable with what you are using, that ultimately is the one and goal of controlling the hypertension. So that was good.
Perfect. Dr. Chandramukhi, any comments about the second case and overall as a closing comment, anything you have?
Yeah, regarding the second case, I would also prefer to move the beta blocker in the morning and calcium channel blocker in the evening or night time. And it is true that we have to individualize our therapy according to the patient's subset and the drug therapy.
Perfect. Thank you so much, ma'am. Dr. Praveen, closing comments. Dr. Johan, I'll get back to you.
Okay.
Sir, actually, I what you call had the question because we had one patient who was using cilnidipine plus telmisartan, sir, in the morning, and his blood pressure is adequately controlled. But recently, his because of his job, he was doing the night shifts. So taking the drug in the morning, there was increase in blood pressure. We have done the ambulatory blood pressure. The surges were also in the evening. But shifting the drug to the evening or in the night time, just before his work, the pressures were not adequately controlled. I had a doubt whether the timing will be having any effect, and so that's why I raised the topic.
No, truly speaking, the clinical scenario that you brought up is very important, and I don't think we have very good answers for that, which is when you change your shift or when you change your work hours, because your circadian rhythm, whether that follows your change in shift, that we don't know. And that is where I think getting the ambulatory blood pressure machine, making sure patient sticks to a routine, whether it is daytime or nighttime, and then you tweak around some of the drugs, I think that is going to be very important. Dr. Johan, your comments? Dr. Jahan, up. Sir, I'm not able to unmute you for some reason. Okay, now you're unmuted. Go ahead.
Yeah, Anoop, just the last thought of the day, as so many seniors have spoken. I think it's a good thing to know your patient well and to know your drug well. I think both these things will go a long way in managing your hypertension very well. That's it.
Perfect. Thank you so much, sir. Anybody has any other last thing? We have Dr. Dinesh from Warangal. Dr. Dinesh, could you please briefly introduce yourself and tell us your thoughts about the session, about the cases we discussed? Please unmute yourself. Okay, having some technical issues. All right. If nobody has any other final comments, I will close this session. We are 11 minutes past 8:30. Thank you all for participating. We had some new attendees here. I really hope we added some value to your 1 hour discussion, and hopefully we'll see you next week. I'm very appreciative of the feedback I get, and if you have any other feedback, please reach out to me, and I'll be very happy to incorporate it. If you have any topics that you think we should be discussing, please let me know that as well, and we'll discuss that as well. And thank you all for coming again, and have a good night. I will be closing the session.
Good night.
Thank you, guys.